My talk is about CTFFR, but in general, it's thinking about how are we changing our practice in clinical care. And again, I appreciate the opportunity to be here. These are my relevant disclosures. I do get research grants from HeartFlow, who does CTFFR, and have been involved in some of those studies that I'll talk about. So what's the current challenge in cardiology, or I'll just say even clinical practice? It's still the challenge all of us face, which is you have a 55-year-old female who comes to your clinic and complains of some chest discomfort. And according to the guidelines, a 55-year-old woman, even if she has typical angina, she's intermediate risk for having coronary disease. And you might say, well, how can she be intermediate risk if she's 55, has risk factors, and might even tell you that she has a very classical story? Well, the guidelines dictate that intermediate risk is 10 to 90%, and that you should then do a stress test. And as you all have seen before, we've done stress tests. We've taken people to the cath lab, and we've seen, at least in the past, this we published in 2010, that patients who go to the cath lab, we still have at least 40 to 50% of patients that don't have obstructive coronary disease. It's certainly reasonable to do it, but you want to know better ways to take care of these patients. That led to this trial that some of you might have seen, CT. So before you can talk about CTFFR, you have to talk about CTA. Say, how does coronary CTA work? This is the NIH-funded PROMISE trial that randomized 10,000 patients to an anatomic strategy of 64-slice CTA versus a functional strategy of stress testing, exercise ECG, routine follow-up with at least 12 months, and then follow-up farther to see what their cardiovascular endpoints were. This was published in 2015 in the New England Journal, and it showed that these were patients that we anticipated. 52% were women. NIH-funded study where more than half were women. They had hypertension, 21% had diabetes, 67% had lipidemia. This is typical or atypical angina was present 90%. The pretest probability of coronary artery disease was 50% in these patients. So people you would send to a stress test were randomized to CTA or functional study, these 5,000 patients. These are the primary findings of the trial. In extended follow-up, the functional study and the CTA were similar for cardiovascular death and MI. This is a secondary endpoint. The primary endpoint was similar. But I put this up because look at 12 months. Even though a secondary endpoint, death or non-fatal MI, there was less of that with CTA. And you might say, how can that be? Were you identifying more left main disease, triple vessel disease? Well, one question I might say is that if it was just one finding, you would say it's hypothesis generating. But by now, you all have likely seen SCOT-HEART. This is a trial conducted in Scotland where they did, after a treadmill test in some patients, they went either to the cath lab or to CTA, patients suspected of coronary angina, or they just went to one of those two randomized trials. This was at 1.7 years, but the 5-year data has now been published in the New England Journal of Medicine. I think this is one of the more important non-invasive test trials in medicine at this point. CHD death, non-fatal MI, and non-fatal stroke was less with CTA strategy than standard of care. In the United Kingdom, the NICE guidelines have now approved CTA as the first-line non-invasive test for patients with chest pain evaluation. If you're a young fellow, you're in training, you're thinking about doing interventional cardiology, I would recommend you certainly get used to looking at CTA and thinking about CTFFR. It will likely play a role during your career in how you evaluate patients. Well, how about HeartFlow? What is the idea of CTFFR? Obviously, it's using computational fluid dynamics to look down the vessel to see if FFR is meaningful. Could we predict that? This isn't the only technology. There are other technologies now doing that. These are the 3 major trials that directly compared FFR-CT to invasive FFR, Discover Flow in 2011, De facto in 2012, and an NXT in 2013. Some initial pilot studies and then international studies. And if you think about FFR as your gold standard invasive pressure test to tell me about ischemia in that vessel, then you can think about here, if you look at all the studies from different modalities, this is where next FFR-CT fit. We then conducted the platform trial where we took patients who were going to an evaluation in Europe, observational prospective registry, where patients were either going to get a CT or they were going to go ahead and use their usual testing. And there, the planned non-invasive testing, whether it was usual care or FFR-CT, didn't have a difference in clinical outcomes, but you can see the planned use of cath lab or invasive coronary angiography was less. So what's the new data? This was presented at ACC, and I'll present it to you here again. It's now published. This is the impact of FFR-CT on 1-year outcomes, lessons from the advanced registry. This is a international registry of patients undergoing CTA to see if it changed practice patterns or management after they got an FFR in that CTA. I present this on behalf of a variety of investigators, including Jonathan Leipzig, Tim Fairburn, and others. So again, just to think about where we are in the clinical practice of medicine, we have patients who have anatomic testing with CTA or functional testing with treadmill, stress test, stress MRI, or echo. And ideally, if you could do both anatomic and functional testing, if you could actually get their FFR value prior to the value of the test, if you could actually scroll up and down the vessel to look at the vessel size, to think about that, that would be valuable. I would suggest we're not fully there yet. You have to have the data, but when you look at these types of figures and you start to do this, you'll get more comfortable. We've done the 5,000 patient registry, and we are the core lab for at least the FFR-CT portion of this. I can tell you, having looked at several thousand of these, there are places where it's important to understand how to read them and to understand how the technology works, but nevertheless, it is moving the field forward. So here is the advanced registry findings. We took 5,000 patients, and the goal was to understand the use of FFR-CT in real-world practice to determine the incremental information provided by it and understand the downstream procedures and outcomes. So 5,083 patients got this study at 38 sites in Europe, North America, and Japan from July 2015 to October 2017. So in 2 years, 5,000 patients were randomized, and you can see about a third or maybe a little bit more in Europe. Events were adjudicated by a central adjudication committee for death, MI, unplanned hospitalization for ACS that led to revascularization. And then the primary endpoint was how often did the FFR portion of the CT change what you thought before that, so that you would do a CT and say, okay, I'm planning on cathing the patient, I think we're going to medically treat the patient, and then you got the FFR information and it changed you reclassified what you were going to do almost 67% of the time. 90-day outcomes were presented by Tim Fairburn at ESC, and then at ACC we looked at one-year rates. Remembering that we were trying to understand, just like you do in clinical practice, can I defer doing something to this patient if the FFR-CT is okay? Much like in the coronary vessel, if the FFR is okay and I don't do something to that patient, what will be the rate of events? So these are the one-year results. To remind you, there were 5,000 patients. Some did not have an FFR-CT planned. Then we looked at those that were non-analyzable, again, about 3% of the patients. About 2% were lost to follow-up at 90 days. Another 300 patients, or 7%, lost to follow-up at 1 year. So this represents 93% of the patients, 4,200 patients. It's important to think about a third of them had a negative FFR-CT and 2/3 had a positive FFR-CT. This shows the baseline demographics of the patients. So you can see they were 66 years of age, and you can see those that were where we had follow-up and those where we didn't. And again, similar findings, similar age, similar types of chest pain and discomfort. Similar rates of diabetes, hypertension, and CTA findings. Again, as I said, about 2/3 of the patients had an abnormal FFR-CT with a value less than or equal to 0.8, and significant stenosis, at least visually, was variable across the population. So these are the results of revascularization. How often did these patients go and get a revascularization? So on the left, you can see based just on the FFR-CT, and as you can imagine, even after the first 90 days, if the patient had a greater than 0.8 FFR-CT, they at least did not seem to have symptoms or come back to the clinical practice to get revascularization more than 5% of the time, compared to these patients who were getting it 35–40% of the time. This is now by degree stenosis. So if you had a stenosis greater than 50% and a FFR-CT less than 0.8, this is the top line. If you have a negative, less than 50% stenosis and a normal FFR-CT, that's the bottom line, and in between are the two different variables, and you can see that the event for revascularization is somewhere in between that practice. The MACE rate for mortality MI was low. You can see the CABG rates here too for revascularization, PCI and CABG, and you can see low rates of revascularization from 90 days to 1 year. These are the clinical outcomes at 1 year, again, by FFR-CT of 0.8, greater than 0.8 or less than 0.8. And again, you can see for all of the clinical events, there's a trend towards a difference for those patients based on their FFR-CT. And if you look at cardiovascular death and MI, the p-value is significant. Obviously, this is an observational registry, but you can see that FFR-CT that is fairly normal has a low rate of events out to 1 year. This is comforting if you're doing FFRCT, or just like in the cath lab where we now do pullbacks. If you look here, you can see that the FFR value of the CT as it goes up, the MACE rate goes down, so that if you have a low FFRCT, your rate of events, death or MI, even though low, are correlated to the physiologic degree of reduction across the board. So I appreciate the opportunity to present this, but in summary, I would say overall in this study, the patients had low rates of MACE at 1 year. MACE events were progressively higher for lower FFRCT values, and the vast majority of patients had an FFRCT greater than 0.8 and an initial conservative non-invasive management and lower rates of revascularization at 1 year. Those patients that had a normal-ish FFRCT trended to have lower rates of MACE and lower rates significantly of CV death and MI. So where are we right now with CT or FFRCT? There continues to be emerging data with coronary CTA. I would say clinical practice is still limited by experience and the opportunity for our practicing patients and clinicians to get used to it. This registry does show, though, that now payment is occurring and people are using it in clinical practice, and in clinical practice, we were able to enroll 5,000 patients in a few years and show that their clinical events were low, especially for those that had normal-ish FFRCT. And this overall low rate of MACE in these patients highlights the need for ongoing efforts to refine our pretest evaluation and risk assessment. There is an ongoing trial called PRECISE where that is. And finally, I guess I would say there are lower rates of revascularization in clinical events in patients with an FFRCT greater than 0.8, and these were managed conservatively. And so if you did that in your practice, you should have at least some reassurance that your clinical strategy would lead to those findings. Thank you.